medical health professionals in the community who are standing by, who are active, who are frontline, and they are committed to proper information and service that you can rely on. Our job is to elevate their voices and share with you information that you can trust, that you can believe in, and give you the vocabulary, the tools to navigate yourself, your family, your community safely, particularly now during the COVID-19 crisis. Dr. Sean Eniver is kind of co-hosting with me today. Dr. Sean, how you doing today?
Very well, thank you. Thanks for having me.
Before we turn it on, we're both talking about our Jamaican and Irish and Scotch roots, so good to meet a fellow Jamaican. Also here, co-hosting with me as well today is Dr. Melody Brown. And Dr. Brown, thank you so much for being here. Thank you for inviting some other physicians to be on board today's program, and I'll have you introduce them. But first, let me talk about you to our audience here. Dr. Melody Brown is the program director for integrative medicine at Children's Hospitals and Clinics of Minnesota. And she's associate professor of pediatrics at University of Minnesota. She focuses on empowering children and families to live their highest quality and healthiest life using an integrative approach. She's the current program director of integrative medicine at Children's Minnesota. She's also the chair-elect of the American Academy of Pediatrics. She has written a number of articles and international curricula on integrative medicine, integrative pain management, and pediatric palliative care. She's a former basic science researcher who developed a transgenic mouse model of asthma, critical care physician. She's worked over a decade in intensive care unit as an intensive care unit physician at a level 1 trauma center on the south side of Chicago. And she was also the medical director of the pain palliative care and integrative medicine program at the University of Chicago, where she also served as director of Healer's Art, a course that helps medical students find the heart of medicine, and that was at, I think, the Pritzker Institute, or Pritzker, what was it?
Yep. Yeah, the Pritzker School of Medicine.
School of Medicine, great. And then just briefly, I'll tell you more about Dr. Sean Eniver. He's an anesthesiologist who practices medicine in St. Paul. And he says he endeavors to ensure the safety of patients who are about to undergo surgery. And, anesthesiologists specialize in general anesthesia, which puts the patient to sleep, sedation, which will calm the patient or make him or her unaware of the situation, and regional anesthesia, which just numbs a part of the body. So as an anesthesiologist, Dr. Eniver might also help manage pain after an operation. Began his career in medicine in 1994 when he graduated with his medical degree from the University of California at Los Angeles, the UCLA School of Medicine, Los Angeles. After medical school, Dr. Eniver completed residency at Yale, New Haven Hospital, he's a board certified anesthesiologist, certified by the American Board of Anesthesiology, and currently provides care to patients in St. Paul. Well, I'm being tongue-tied today for some reason, so I apologize to all of you. But Dr. Brown, let me ask you to introduce Farah Cassis, and if there's somebody else on board, make that introduction as well.
Well, thank you so much for that introduction. I'm actually going to let her introduce herself, but Dr. Cassis Govami is one of our really fantastic infectious disease doctors in pediatric infectious disease at Children's Minnesota. And I will just tell you that she is someone who I will often call or ask if I have any questions. She is amazing, and I am so glad that she was able to join us for a little time today. I think it's a busy clinic day for her, so I'll let her introduce herself.
Hi, thank you for inviting me. My name is Farah Cassis Govami, and I am a pediatric infectious disease specialist over at Children's Minnesota. I did my medical school training at SUNY downstate in Brooklyn, and did my infectious disease fellowship at Vanderbilt University Medical Center. And then after that, was working in research and clinical infectious diseases over at Seattle Children's and Fred Hutchinson Cancer Research Center before I joined Children's Minnesota, and I've been in St. Paul for about 4 years now at Children's Minnesota.
Great.
And I see that we also have, so thank you so much for being here. We also have Dr. Cederstrom. She is the head of our ethics department at Children's Minnesota. So I will let her introduce herself as well.
And she has to unmute her mic, Dr. Cederstrom.
Can you hear me now? Hello, is everybody hearing me?
There we go.
As I'm unmuted. Oh, there we go. I was like, it says I'm unmuted, but I have no idea. I'm up north in northern Minnesota right now, so my connection may be a little spotty. But I'm the director of the clinical ethics department at Children's. I've been here for 4 years. Previous to that, I was the director of the clinical ethics department at MedStar Washington Hospital in Washington, D.C. For about 15 years. So I'm happy to be here. Thank you.
Great, thanks to all of you. Let me start, Dr. Sean, by asking you kind of what's top of mind as you pursue your profession, seeing patients, particularly as our state joins those states preparing to open up. What does that mean? And what are your concerns as a physician?
Well, thank you, Al. First, just a little minor correction. I have not been practicing here in Minnesota for the last 4 years.
Okay.
I do business development for a medical device company and raise money for techpreneurs. I'm treasurer of the Minnesota Association of Black Physicians. And so I keep my connection with the community through some philanthropic work and direct advice to individuals who ask. Presently, I think case tracking comes to mind as a big issue moving forward as we transition to open. A lot of businesses are under pressure to resume operation, and there are complexities that are quite challenging in that regard. I hope that this forum can help answer some of those issues for individuals as far as how to proceed safely. And then also we can hopefully encourage people to share a lot of information regarding where they've been, if they've been ill, who's been exposed during that time. And hopefully we can strategize a way to move forward as we reopen our economy, if able.
Melanie, jump in. Dr. Brown.
Hi,
Yeah. Everybody, this is a open conversation. So when things come up, just jump in and let's share.
And I invite everyone to step in as well. I think that's really such an important point. And across the country, what we are looking at is, we're really looking at how do you balance the health and safety needs of our population with the economic needs. So we know that there are a lot of people who are out of work. We know that with businesses shut down, that's had a really significant economic impact. So as a physician and a part of the medical system, I really think about, as you said, as we are opening up and as we are starting to go back, how do we really keep ourselves as safe as possible during this time? And I just want to reinforce some of the things that we talked about last week for those who were here. We still say that, some of the behavioral changes are some of the most important things that we can do. So yes, things are opened up, but I think the recommendations still remain for doing proper hand hygiene, which means, washing your hands thoroughly, masking up to protect others particularly, but by protecting others, you're also protecting yourself. So when you're in those situations, masking up. People talk about, now that the summer's here and folks are going to want to gather, being very thoughtful about, who you're gathering with and how you're doing that. Understanding that, being in an open air space for a physically distanced picnic might be or is a lot safer than meeting in a enclosed home where you are, subjected to sort of the airflow issues that are there. And I know that our infectious disease doctor could talk about this in more detail, but just still being really thoughtful and mindful of all the things that we've been doing over the past few months to really flatten that curve and to keep everyone safe. It's really the same principles that we're going to do and use once society is opened up.
Dr. Cedarstrom, would you weigh in here on how where we are as a community affects your discipline and your approach to work? And you have to unmute your microphone.
Can you all now?
Almost.
Yeah, it's like a delay in the unmuting. Push button.
Okay. You're not coming through. Well, let me just ask, pass on to Dr. Gabani. Dr. Gabani, can you weigh in on the question? How do we look at this notion of opening up now? How do we advise both our family, friends, community to be intentional and be safe as we change the operating procedure for the state and for the community?
I agree with Dr. Brown. I don't think we should really change any of the practices that have been recommended by, the CDC or the Minnesota Department of Health. I think we should still follow safety precautions as far as, wearing masks if we're going out in public, washing hands, preventing touching, our face, particularly our eyes, our nose, and our mouth. As we open up, we just need to be mindful that we still need to carry through those recommendations. And that doesn't mean that we're going to lax those recommendations. And if we are outside, again, as Dr. Brown said, being mindful that we're in open spaces as opposed to closed spaces, making sure we keep our 6 feet of distance. So I think the summer will look differently than most summers that we're used to. So the big gatherings, in home, the family vacations in crowded places. But I still think that we can have an enjoyable summer. We just have to, just modify it and continue to be mindful that, we are still in a pandemic. And so we have to take precautions.
So I'm curious, this is for all of you. I'm an average, ordinary citizen, a dad, an elder, grandpa, and everything. And so I want to be safe and practice, follow the guidelines, keep myself distant from, opportunity for, bad outcomes. But how do you all handle? I mean, you're trained to be on the front line. I'm curious what goes through your minds as you assess the risk you take and the risk people in your profession take in discharging their duty, their responsibility, their desire to be of service to community and humanity. And I'll ask each of you to respond to that, because I kind of wonder what goes on in your mind. What are you thinking? What's your internal dialogue as you prosecute your daily work?
Well, I mean, this is Dr. Gavami again. I mean, to me, I because I'm an infectious disease doctor, it's no different than anything I do, because, there are other infectious diseases that are contagious that, I have to manage patients. And so this is just, to me, another infection that I have to take care of and, manage people that have this infection. I think the reason why it's harder for other people that are not in my profession is just, they may not be as familiar with, all of the extra precautions that we have to take. So when I approach it, I don't necessarily really approach it with fear or treat it any differently, but I am mindful that other people may not they're not in the same profession as I am. And so my job, in addition to taking care of the patients, are also supporting my other colleagues that may not be used to being in a situation like this, and helping them navigate, how they can stay safe, keeping their family safe, managing patients. So to me, it would be interesting to hear what Dr. Brown and the other panelists have to say, just because, again, they're not infectious disease doctors. So it'd be nice to hear from their point of view, how they're seeing it through their lens.
But Dr. Yabani, as an infectious diseases physician, do you put this experience in a context that goes back many years, and do you regard this as part of a continuum that will likely occur again in future? And so is there a certain calmness that you can bring to your work and to your analysis of the situation based on your particular training, knowledge, and specialty?
Well, I think to this extent, the way the pandemic is, the numbers, I don't think we've seen anything in, recent history, probably in the, last, 30 years or so, of something like this. But on a smaller scale, there are other, infectious illnesses, tuberculosis. I'm pretty sure when people first came around with HIV and they weren't sure about this, virus, they didn't know, how to navigate it. Although, it wasn't contagious the way that, a coronavirus is. But if we look back at history, there are other infectious illnesses, bubonic plague, other illnesses, tuberculosis way back before we had treatment that were really infectious. But I think the reason why we're kind of, quote unquote, not prepared is just that, we have relatively good medicine, and we haven't seen, a wide scale pandemic like this in quite some time.
Go ahead, Dr. Brown.
Yeah, and I would say that, some of the practices that we learned during those previous pandemics that Dr. Ghavami was talking about are some of the practices that we're using now. And I'm fully confident that as our world is, very global, and as we continue to have potentials of additional exposures, the things that we are learning during this time, I think, will serve us very well for anything that may occur in the future. The other thing, when you talk about, so we are out there, and I am still seeing patients, and I have a family. And so those are things that I think about when you talked about that internal dialogue. But there are also things that we can do to keep ourselves safe. And those are some of the things that I do. So when I am in the hospital, when I come home, the first thing I do is I sanitize and I wash my hands. So I actually use soap and water, because I think that if you have the option of soap and water, that's absolutely the best way to go. So I use soap and water. I take my clothes off, I take a shower, and I do all of those things to make sure that I am keeping everyone that I care about very safe. But also, when we're seeing patients, when I'm out in the community, and for those who are going to be now, going to the grocery store, doing those things, making sure that you are following all of the guidelines that have come down from the CDC, and you're doing those things to keep you safe, makes me feel more comfortable. But we also know, as testing is increasing, I think that we really don't know how many of us have maybe been exposed. There are lots of people who are having very mild illness. Unfortunately, there are some people who are not. And as we know, within the Black and Latino communities, I think that, sometimes there is some increased exposure, and we are hearing a lot more about the disparities that are coming up, and the way that our communities are sometimes disproportionately impacted. But there are lots of people who actually do well, even in our communities. You hear the stories of someone's, one of my friends, their grandparent, I think, was in their early 90s, and she had COVID, and she's since recovered. So there are these beacons of hope that are out there. And so what I try to really focus on are those things that I can control. So there are plenty of things that I can't control, but there's a lot that I can control. So we talked a lot about behavior. So, controlling that behavior, doing the hand washing, covering mouth and nose, staying apart, the distance apart, doing all of those things. But then I also think about other lifestyle things. And we talked about this a little bit last week, but there are actually studies that show, there was a study that looked at the common cold. Now, the difficulty with COVID-19 is that this is new. I mean, it may not feel like it's new because sheltering in place for a few months feels like it's been a really long time. But this is new. This is a new thing that we're seeing. We have seen other pandemics, but certainly not in the global age that we're in. So this is new. And because it's so new, there aren't a lot of, as physicians, we often like to go to the literature. And we like to look at like, what is that peer-reviewed research, which really means like, what is that research that lots of other, people have looked at and have said that this is a really good study. This can give us information on how to move forward. But for COVID-19, there are a lot of sort of opinion papers. There's a lot of papers that take our best, knowledge from other things that have happened, but there's not a lot of peer-reviewed research out there that's been published about like the effectiveness of some of these things that we're thinking about with treatment. And we hear about that in the media when, whenever there is something new that seems great, we all want to sort of like latch onto that and we want to use that. So sometimes I'm looking at the things we know about other stuff. So like the things we know, coronavirus, not COVID-19, but coronavirus is one of the viruses that sometimes causes the common cold, right? And so I will look at some of the things that we know that can help with a cold or a virus in general. And if it's something that is safe to do, then those are the sorts of things that, I am looking at doing when I think about, how do I keep myself sort of safe and healthy, knowing that at some point it's very likely that I will be exposed.
Mm-hmm. That's amazing. Go ahead, Dr. Sean.
I'm just in agreement with Dr. Brown with focusing on the things that you can control. There's a lot of unknown. We're in an age of instant information. We don't know a lot about this particular virus in a manner that's agreed upon. So we don't have a best of practice yet for recommendations to individuals. So when I interact with small business owners to large private equity firms, a lot of the questions revolve around a timeline. When will a vaccine be available? When will be a definitive treatment, meaning an adjuvant or an actual medication? I recommend doing what you can control, which is garnering information to the best of your ability, taking that to your local experts, be it friends, providers, and asking, for instance, with the vaccines, what kind of vaccines are there? Is it an mRNA-based one? Is it a recombinant one? Is it an inactive? Knowing the differences and kind of checking on the progress as each entity puts forth their information, but tempering that with, in this day and age, there's a lot that's done for secondary gain. So sometimes results are shared prematurely, and that can be due to economic pressures. There's a lot of pressure in the community to resume as we were, because that's what's known. And it's an unknown time. And in having an econometrics background and basic science background, I try and remind people that even though we're looking for predictable models, we don't always have predictability. What you can have is consistency in yourself as an individual or in your peer group or in your family. And the thing that you can control for peace of mind is your daily routine, your sleep, your exercise, your information, educating yourself as best you can, and gathering that information from a source that you trust. And then waiting for the professionals to come forth with a plan, and hopefully one that's embraced by the community and the leadership that we can execute. There'll be no perfect plan though, just like there's no magic anything in life. The best you can do is try and benefit as many as possible, and you need to customize that as an individual.
Dr. Cedarstrom, can you try to test your voice with us again? Your mic was muted. Let's see how we can hear you. Can you speak?
Can you hear me now?
you're way faint in the background. I don't know if you can come closer to your microphone, if that'll make a difference or not.
Is that better?
Much better, much better. Thank you for being
here. Can you hear me now better? Okay.
Excellent. And if you want to turn your video on, you
I
can.
agree with.
Go ahead.
I'm not sure how well it's going to come through in this cabin, but I'll try my best.
And sometimes there is a better connection.
So I would just. Yeah, let me try that.
So she's going to come back in a second, I think. And so, Dr. Sean, so I have used the term in my writing. One of my intentions or my obligations is to be part of crafting a public mind in our community. And I'm wondering, does the challenge that we're facing now, since it is global, since it is a pandemic, since it's on the top of mind of everybody, is this an opportunity to reshape how, as a public, as a community, we understand and take responsibility for the things we can control and our practices, and can that be a net positive outcome of this? Not only a positive thing that we've had the skill to do, but a requirement if we're going to survive and be whole. It's more than something we elect to do. It's something that we must do. So I'm thinking out loud, but I'm responding to what I heard you say. How do we change, or can we, and will we change the public mind, the understanding of what our health means and our responsibility, so we don't surrender that to somebody else, but we say, you know what, I can do these specific things, A, B, C, D, and that's my share, that's my part. What do you think? And Dr. Cedarstrom, just jump in whenever you're ready.
I'll take it to start. I'm in absolute agreement, Al. I think having a positive outlook is tantamount to success. And part of that is being magnanimous, not politicizing a lot of what's going on, not internalizing that rights are being taken. For instance, if we hopefully can implement contact tracing, being compliant with that, sharing that information, because that's the magnanimous thing to do. You can show by example that you're doing things that are for the benefit of others. And in doing so, hopefully enriching yourself and your community, because it is a global issue and it is for the greater good. It is a perfect opportunity for us to come together synergistically, all communities, not only the underserved, but the majority, to kind of see that long-term vision. In the Japanese system, in business, it's called the Kanban system, and it's a long-term view of things, everything from loyalty of employment to dedication to your craft. And those are the things that we can focus on as an individual. And I personally find that a positive outlook tends to build a better immune response. So that's how I try and advise people to kind of look at the pearls that are there, that it's half full, not half empty, and question, though, what's being purported to be accurate. And always question and do that collectively, though. You don't have to do it in isolation.
And I just want to say there's actually research to back up what you've just said about positive outlook and immune response. And, there's research that looks at things like meditation, and that mindfulness meditation, has been shown compared to a group who's not doing that to reduce the severity of cold. So the things that you're saying there, it is true. And there's actually data to back it up. But I see we have Dr. Cedarstrom, so I would love to hear from her while she still has a signal.
We're going to try this again. Yes. I hope that this is.
I think we just lost you that quickly. Just like that, she'll come back again.
You will. So,
here she is again. Go ahead, Dr. Cedarstrom.
Okay. Sorry about that. I think I would just only want to add that we as a community just be mindful of all the positives that we have in front of us. I mean, this opportunity to be closer to our families, to be able to
Can you all hear her? Can
learn
you
who
hear
we
her?
are, we need to embrace it.
Okay, go ahead.
Can anyone hear me?
Yes, I heard
Yes?
you say that
Okay,
this is
sorry,
a time
good.
to be, yep,
Um,
mindful of all the strengths of
yes,
the
thank you.
community.
To be embracing it. I know it's a lot of additional stress, and with the news coming out about how our communities are being affected.
Oh, the technology here. There you're back. Okay.
Didn't get that last bit.
Didn't
Did you
get
hear my last little bit?
We did
Okay.
not.
I was just saying we need to be mindful and positive, be as positive as we can and to make it through.
Yeah.
Okay, that's great. Yeah, the
Yeah.
connection is really difficult, Dr. Cedarstrom, but thank you for being here.
Yeah. And then the other thing that she put in the chat, I don't know if you saw this, but she did say that she wanted to make sure that people knew that through her work, they're looking at equity and triage protocols. So actually, if there could be protocols to really help making sure that people are getting the care and the treatment that they need, even if there is a disadvantage because of the way the system is structured and set up. Through her work with protocols, she's really trying to address some of those disparities that we see.
And so what does that mean? What does that mean exactly?
So,
let's see, can you all hear me?
Yes.
Yes, I'll try to answer that really quick before I fall out. So what that means is we've talked a lot about resource allocation and scarcity of drugs and scarcity of things like ventilators. And so what I'm trying to do is ensure that even though we have these scarcity issues, that African American and other populations of color don't get disproportionately disadvantaged on top of already being disproportionately disadvantaged as a result of the systemic racism that our healthcare system is embedded in. So what I'm trying to look at is ways to ensure that when we have to decide who gets what drug or who gets events or any of those big allocation decisions, that equity is part of the discussion, and then we ensure that there is some level of intentionality in the decision making to allow for populations of color who would have normally been discounted.
That's a powerful
I will
statement.
say I love that her microphone worked to say that.
We heard most of that. That was powerful, Dr. Cedarstrom. And if you want to continue, please do. Keep going.
So I don't know where it jumped off, but just basically I'm trying really hard to make sure that intention is there and the decisions that are made truly look at what really is a positive and appropriate outcome and not just what the numbers say.
So this morning on public radio, I was listening to a debate about ACT and SAT test. And it seems unrelated, but I'm going to put that into this equation about what you just mentioned, Dr. Cedarstrom. And the question was either legislation proposed to either discount or to create as an option the utilization of SAT and ACT tests for college admissions. This was being debated in California. I think they decided to put that in a not mandatory, but now an optional mode. And the thinking was it gave people, I think the thinking was in the name of equity, making sure that where there were structural disadvantages, our communities were not locked into the consequence of the disadvantage. And one of the persons testifying on the radio program talked about her experience growing up and having summer camps every year for testing and ACT preparation and having private tutors. Parents were able to pay like $90 an hour, $100 an hour for tutors over a period of time, so thousands of dollars. But all of that led to this person's capability to enjoy and benefit from the access to her college career. And that set of opportunities simply didn't exist for a lot of other people. And because it didn't, it diminished their opportunity for the same performance, same success. So this kind of sounds like equity a protocol of equity to ensure that zip codes and histories don't automatically lock you out of the opportunity for safety and for services in health and in prevention. Am I on the right track in this analysis?
Yes, you are exactly on the right track. Because of historical redlining and gerrymandering and all the things that we know that have caused access to care to be affected, we have to be way more deliberate in how we make decisions. Because if we just data of this patient has a comorbidity versus this patient doesn't, and so the person without the comorbidity gets the vent versus the person with the comorbidity doesn't, then you're going to deliberately kick out a lot of people who are only in this bucket because of structural racism and other external factors, and have nothing to do with the fact that that comorbidity is sort of a marker for an unhealthy person or a marker for someone who would not benefit from the allocation of the resource. So we have to really be clear on why we're making these decisions, why someone would get an allocation of a ventilator or medication over another one. And it can't just be based off these subjective things that are affected specifically because of racism.
Are there models? So this morning also, I was talking to a Somali entrepreneur, a woman who owns several businesses. She and I were on a conference call last night discussing what businesses can and should do, and whether there are ways we can collaborate, particularly in that we've all been impacted at one level or another by the COVID-19 pandemic and the shutdown. And she expressed her frustration that too often we don't collaborate, and that we allow ourselves to be in silos or not connected. And I'm wondering if there's also a parallel here. Where I'm getting to is, what is our obligation, not only to ourselves as individual, but to the public good, to the common good, to public policy, to economic policy? Where do and should our voices weigh in? And how do we impact or affect outcomes by ensuring that we're at the table? And I'm saying this carefully, Dr. Inover, because I know you talked about not politicizing, and it's not politicizing for the sake of partisan politics, but political in the sense of how do you organize for change and for advancing community, society, economy, et cetera. How does that play? How does making sure that our collective good, as voiced by us, is part of the public decision-making apparatus? What do you think, Dr. Inover?
I think a forum such as this is a key starting point. Having experience in venture capital based in California, actually, to allow people to come to the table that are not normally represented. The narrative over and over was the same individuals in the room who were approving financing, greenlighting things. They were not of color. Mm-hmm. Their gender was traditionally male. So just to have us in the room really impacted change. But part of that has to start in a grassroots effort. So within the community, having this sort of discussion, having a small business loan for that business owner, the Somali lady, may not be possible unless collectively she can band together with other business owners mm-hmm. to make a better value proposition to a bank. It's a different discourse that I have with a large private equity firm versus a small business owner. And that collective alignment doesn't exist in communities of color traditionally, because we've been shut out of a lot of access to funding. And that being shut out is not only with economic ramifications, it's also socioeconomic ramifications, which then leads to your healthcare, your access to care, all the things that this panel has been discussing and putting forth is falling on deaf ears unless we are able to take that to our political leadership. So in some ways, we do have to politicize it. And part of that is this look at the panel that you've put together is wonderful. It's excellent representation of those that have been underrepresented and fighting to have access to care. Part of that comes from the economics of medicine. And it's a very complicated discussion. But first and foremost, let's talk about caring for ourselves as individuals, which collectively cares as a population for everyone. Mm-hmm. And then that impacts a healthy business environment. There's no sense in opening your park, let's say, if everyone is ill. And that's being lost in a lot of this discussion, this push to open without the concession that, well, who are you serving? I understand you have bills to pay and things of that nature, but if collectively we come together and maybe we forgive next month's mortgage, maybe we forgive the interest on this loan, there are a lot of things we could do as a community if we pool together resources to help that entity bridge that gap. And part of that is informing yourselves, though, of the inequity and of the lacking in the system of the resources that need to be supplemented.
Well, this was a great conversation. I'm Al McFarlane. This is Conversations with Al McFarlane, our Friday session every Friday at around noon. And we dedicate this session to the theme of serving the underserved, and pleased to have members of the Minnesota chapter of National Medical Association. Dr. Sean Enever is the president of the organization. Pleased to have them on board collaborating with us, and thanks to Inel Rosario, Dr. Inel Rosario, for organizing and bringing us together to have these conversations. I am learning so much personally. I'm hopeful that the capacity to share these conversations over Facebook and YouTube and other social media brings benefit to those who are connected. I'm hopeful that people that are watching will like and share and bring their friends and their networks to this conversation. We will use this content not only for the purpose of this direct and rich conversation, but to create news stories for our newspaper, Insight News. And if you're not familiar with it, go to internet, www.insightnews.com. One of the major features we did last week was stories on a Harvard financial educator. His name is Stephen's last name. Well, I'm of the age that I forget. Okay, but it'll come to me in a second. But Steve talked about, Professor Steve Rogers talked about encouraging Black businesses, agencies, organizations, community groups that are eligible to apply for PPP funding and the EIDL funding for businesses and organizations. And I wonder how the medical professions that you all are involved in are able to utilize resources like SBA and COVID funding to support your work and your endeavor. Is that a fair question for any of you? If it is, please respond. If it's not, it's just out there. So, Sean, what do you think?
I think there are limitations to a lot of what's offered to the traditional small business community. And most medical practices of those that are still private practices are on a scale where they don't quite qualify. So it's quite the conundrum. The business of medicine is very complicated in this country. We talked about our Jamaican roots in relation to Europe. The way those are financed is very different than this US model, which is a lot of fee for service and reward for procedural intervention, and not a lot of consideration for the power of thought and preemption and prophylaxis. And it's refreshing to have experts on this panel who dedicate their careers to a lot of prevention and providing equity to those that don't have access. And unfortunately, that's not something that's attractive to private equity and other entities that want to fund things. They want that quick solution. So hopefully we can have an opportunity to change that narrative, that there is worth in investing in the long term and in communities of potential, which we are a community of tremendous potential and need that opportunity to succeed.
Dr. Cedarstrom, what would you say is the, paint me a picture of the future of of Black people in the health profession, both as professionals, but also as entrepreneurs or as part of collectives that that you can look at and look at the financial models of the financial consequence. I think we're not trained to see the revenue streams associated with healing and with prevention and with healthcare. The common person is not. I think we need to change that so we understand that health is a big business and we all have a part to play, and our choices matter in how we develop more access and better access and a sense of control of our health individually and collectively. What do you think, Dr. Cedarstrom? What's a future that you'd like to see happen in that area in terms of educating ordinary people about opportunity and responsibility?
I think that there's a lot of opportunity available. I think one of the really potentially positive outcomes of this pandemic is that everybody's got to figure out how to be a little bit more creative. So there's an opportunity now for new graduates of colleges who are trying to go into technology and medical devices and medical science to come up with improved telemedicine opportunities, to come up with ways of integrating with communities who have usually had bad access, whether it's because of inner city complications or if it's rural America and they're not able to just find physicians who are able to be part of their community. But there's a way to now make the gap smaller. And I think that there's so many avenues that people of color in medicine, from being frontline facing physicians and nurses to medical device personnel and engineers, can come up with new and innovative ways to make this social economic gap that has historically plagued our population smaller. And I think that partnering with a lot of the community public health entities and other grassroots organization is the way to go. I think having a Zoom meeting, even though the technology right now is terrible for me, but having a Zoom meeting with players that you normally wouldn't because either you weren't in the same location or to figure out a way to have a face-to-face was difficult. But now you have opportunities to connect remotely and start having conversations that probably were not possible in the past. But what I agree with my colleague Sean here, that we have to look at this and say we can collectively join forces and do more for our community than before. Like, we don't have the same constraints, and we've seen over the last 3 months that we don't need to have face-to-face, and we don't need to have travel in order to be able to connect. And we need to be very intentional about creating these opportunities for us to invent and develop new entrepreneurial opportunities and just show the world exactly the kind.
Lost your voice again. Let me close out about at the end of the hour, but thank you all. But Farah, Dr. Gabani, Cassie Gabani, your comments, just your vision comment about where you see our society a year from now. We're all hoping, obviously, for a vaccine, but I think you would say when we have acquired the ability to respond to COVID-19, there's something else coming down the road. And really it's about protocols to be responsive and preventive long-term. What do you see as a future in the next year or two, Dr. Gabani?
Well, I mean, I'm hopeful. I believe that, this pandemic will put us in a stronger place, both in the healthcare system and economically. I believe that, this pandemic has taught us a lot. Number one, how to come together as community. And as Dr. Cedarstrom said, how to come together in innovative ways that we have never thought of before. So I'm hopeful that a year from now, we'll be prepared for the next pandemic because as history has taught us, history tends to repeat itself. So maybe there will be another pandemic, who knows, maybe 50 years, 100 years from now. But the point is that we will be prepared better than we were this time, so that we will have the infrastructure to, keep people safe, as well as, keeping our economy grounded. I think a year from now also, we will have appreciated the way our communities came together. And so I think it will make our community ties a lot stronger. And I also feel like, a year from now, we will be more creative in the things that we can come up, and do as far as, making our economy better, our health system better, et cetera. So I think this pandemic will teach us a lot of lessons, and we probably will be in a better place than we were, previous year.
Let me close with comments from Dr. Melanie Brown. Same kind of question, Dr. Brown. What do you see in your mind's eye? It can be a year out, it could be 10 years out, it could be 100 years out. What is your vision? How does it inform you?
Well, what I will say is that I have been impressed and amazed by how we have all responded to this. I mean, we have institutions who have said it'll take us years to do telemedicine, who have been able to get it up and going literally in 2 weeks. So what this has really shown us is our resilience, our ingenuity. And when I look forward to what happens in the future, I know that, as people have said, the lessons that we have learned are really going to be that foundation for how we're able to respond to what happens in the future. So I actually think that it's been tough. I mean, it's been really tough, and I don't want to minimize that. But I firmly believe that we are all coming out on the other side of this, much better than we went in, for most of us who have been able to find ways to build that resilience, to make those connections. I've connected with people that I haven't seen in 30 years, and now we're talking every week. So while we may need to have some physical distance, I do think that we've been able to find some strength and hopefully some hope within those social connections.
Listen, I want to thank all of you so much for joining me again today. Look forward to being with you again next Friday. The topic, serving the underserved, and just huge props and thanks to Dr. Ainhoa Rosario and all of your colleagues with the National Medical Association, Dr. Sean Eniver, for your service as leader, president of the NMA in Minnesota, and to Dr. Gabani and Dr. Cedarstrom. Dr. Brown, thank you also very much. Thank you for your service. If you're listening, if you like this kind of conversation, like it, share it, tell people about it. There's a version of it on YouTube. Subscribe to our YouTube channel, and let's create a robust conversation that brings value to our lives and elevates our thoughts, our intentions, and our possibilities. I'm Al McFarlane. We'll see you next week. Thanks, guys.
Thank you.
Thank you.
Thank you.
Thank you all.
Thank
Thanks for
you.
having us.